Well, thank you very much, Dave, for that kind introduction. And I am really honored to be here today, to be affiliated with Ale at this fantastic meeting that Dr. Contreras and his team has put together. So thank you very much for the invitation. Professor Calleja has done a wonderful job really reminding us just how far we have come with our treatments for hepatitis C, beginning with the interferon era. As a clinician who has treated patients throughout this entire era beginning in 1990, to me, the medications that we were talking about in the previous talk and today are no short of miraculous. And here are my disclosures. And today, it's also important to recognize that these medications are also miraculous for our patients, some of whom have made the same long-term journey living with hepatitis C until the DAA era, where they have now been cured. And this is a typical patient, a 54-year-old man who had genotype 3, since we're talking about that today, refused as a blood donor in 1993 and was diagnosed with hepatitis C around 1998. Was treated with multiple interferon regimens over time, but because of side effects, was unable to complete all of them. And in 2018, he comes back with worsening fatigue. And it's clear that he's progressed to cirrhosis over this time. And the question he has, or the questions I have for all of us, are, he has genotype 3, which statement do you agree with? Well, genotype 3 is uncommon, and therefore does not warrant further discussion. The treatment for hepatitis C, genotype 3, and cirrhosis is unlikely to be successful with our current medications, or this patient would benefit from antiviral therapy. And I think, of course, by the end of this talk, we're going to recognize that genotype 3 is eminently treatable and has great outcomes for all these individuals. So genotype 3 is often perhaps underestimated, or the importance of genotype 3 is often underestimated. But it's actually the second most common genotype around the world. Genotype 1 still is most common through most parts of globally, but in certain parts of the world, genotype 3 certainly is extremely common. So for example, in the US, it makes up maybe 10 to 12% of the patients that we see. However, here in Latin America, we're seeing that it's anywhere from 10 to 15%, in parts of Brazil up to 25 and 30%. And you'll see in parts of Southeast Asia, particularly Pakistan, India, genotype 3 is actually the predominant genotype as well of patients with hepatitis C. And really, until recently, our treatments for hepatitis C were rather suboptimal. Genotype 3 also has some unique features associated with it that we have to keep in mind. Through a lot of epidemiologic studies early on in the interferon era, it appeared that genotype 3 had accelerated fibrosis progression compared to other genotypes, and historically lower sustained response rates even in the interferon era. Much higher relapse rates with interferon than compared to genotype 2, for example. There is an increased incidence of liver cancer in patients with genotype 3 compared to those without genotype 3. The burden of disease I mentioned was second most common to genotype 1. And overall, there was an increased risk of mortality. Interestingly, there was also an increased prevalence of steatosis associated with genotype 3 early on that is separate from the metabolic disease risk that is usually associated with steatosis in patients with genotype 1. So there's a direct viral effect that increases steatosis in patients with genotype 3 and may impact some of the other features that I've just mentioned. Now, when we think about selecting regimens for genotype 2 or genotype 3, just as Professor Calleja had mentioned, there are several major issues now that we have to think about. The first is the patient treatment naive or treatment experienced? And if they are treatment experienced, have they received treatment with an interferon-based regimen or a DAA-based regimen, particularly if they had an NS5A inhibitor treatment in the past but did not respond. And similarly, are patients cirrhotic or non-cirrhotic? And if they're cirrhotic, are they Child-Pugh A, well-compensated disease where we hope to decrease the rate of decompensation and decrease liver cancer, in which case those patients really are candidates for any of the regimens that we'll be talking about, or are they decompensated where they're Child-Pugh B and we have different hopes and expectations to cure their hepatitis C, and in which case, as was mentioned previously, protease inhibitors are contraindicated due to alterations in the pharmacokinetics of those drugs that can have an adverse impact on side effects. And Professor Curry will be talking more about the treatment of the decompensated disease shortly. So the first all-oral regimen, if you will, that combined two different classes of direct-acting antiviral agents really combined the cladosphere, the NS5A inhibitor, with sofosbuvir, the nucleotide inhibitor, in the ALLY 3 study. These were patients who were treatment naive. They were treated for 12 weeks with the cladosphere and sofosbuvir, and you see had excellent sustained response rates of 90%. And this was compared to, if you remember, the interferon-based treatments as well as sofosbuvir plus ribavirin-based treatments, which were, at the time, an oral regimen that was available, but also proved to be suboptimal over time. In this study, about a quarter of the patients were cirrhotic. Some of them had previously failed sofosbuvir and ribavirin, as I had mentioned. What we see here is that for the non-cirrhotic patient, the response rates were quite good, 90%. But when you dug down into the patients who actually were cirrhotic, you'll see that the sustained response rate dropped off to only 63%. And there are numerous other compassionate use studies around the world. Professor Calleja had talked about the real-world data. A lot of them supported the utilization of the cladosphere and sofosbuvir. And it's still a very widely used regimen globally. Sometimes that's the only all-oral regimen available in various countries and works for a large number of patients. However, it's no longer the optimal treatment for hepatitis C. And really a major breakthrough for hepatitis C occurred with the development of a combination of sofosbuvir and velpatasvir. In this study, which was the Astral studies, a combination of studies of this drug in various different genotypes, we have patients who are both cirrhotic and non-cirrhotic who were randomized to sofosbuvir velpatasvir, so the nuke plus the NS5A, compared to the nuke plus ribavirin. So the sofosbuvir velpatasvir for 12 weeks or the sofosbuvir plus ribavirin for 24 weeks. And it's quite apparent that you could see the impact of the combination of DAA therapy. You see on the left side, of no previous treatment, patients who were non-cirrhotic had a 98% cure rate compared to 90% of those treated with soft ribavirin. And if they were cirrhotic, the impact was even more dramatic, where 93% sustained response rate compared to 73% of a soft ribavirin regimen. And in those patients who were previously treated, so had gotten PEG interferon and ribavirin, for example, 91% sustained response rate with soft velpatasvir for 12 weeks compared to 71% in those who were treated with 24 weeks of soft ribavirin, and it dropped off even further if you had cirrhosis. But you start seeing a little impact here where patients who were cirrhotic, who were previously treated, even with sofosbuvir velpatasvir for 12 weeks, had an 89% response rate, which yes, it was still much better than our standard at that time, which was sofos ribavirin, 58% cure rate. A recent study demonstrated that perhaps adding our old friend ribavirin could have some additional impact on treating these patients with genotype 3. This was a study specifically for patients with cirrhosis. It was just recently published in Hepatology this year. These are patients who had about over 200 patients with hep C and compensated cirrhosis. They were randomized in an open-label fashion to either soft velpatasvir with or without ribavirin. It included treatment-naive and treatment-experienced patients. And what you see here, the overall sustained virological response rate, specifically in the cirrhotic population, was 96% with soft velpatasvir plus ribavirin, and compared to 91% in the soft velpatasvir group. In treatment-experienced populations, you'll see the overall response rate was 96% here, although a relatively small number of patients in that group. The impact seemed to have the most where ribavirin had an impact. You see in the lower right-hand corner there, in people who had a baseline resistant associated substitution. That could be a naturally occurring variant that renders you less susceptible, usually to the NS5A inhibitor. Not very common, maybe seen in maybe about less than 20% of patients that you see, but just by chance, even if they've never been treated with an NS5A, may have a resistant variant. In this situation, you'll see that the addition of ribavirin in the box there, 96% of patients who had this resistant associated variant who got ribavirin had a sustained response rate compared to 84% who did not have ribavirin. So ribavirin then, in genotype 3 and cirrhosis, ribavirin can mitigate the impact of some baseline resistant associated variants. Another major breakthrough, as alluded to previously, was the treatment regimen that consisted of a protease inhibitor, glecaprevir, and pibrentasvir. Again, in a pan-genotypic regimen. This is a compilation of a number of phase 2 and phase 3 studies that was presented at the liver meetings in 2017. But you see here it encompassed patients with cirrhosis, with non-cirrhotic patients who were treated for 8 weeks, non-cirrhotic patients who were treated for 12 weeks, or cirrhotic patients who got 12 weeks of treatment as well. And this is just a summary of different phase 2 and phase 3 studies. But what you see here again underscores the remarkable progress we've made with being able to treat patients with genotype 3 regardless of their histologic stage. And here we see that whether they got 8 weeks in the non-cirrhotic population, 95% cure rate, 12 weeks, the same, 95% cure rate, and 97% cure rate in patients who were cirrhotic who received 12 weeks of therapy. Very few patients will relapse or not respond to these treatments. And if you look at the compilation, just focusing on the subgroup analysis of people who got 8 weeks of treatment here, you'll see that for F0 to F3, you'll see that the sustained virological response rates were roughly about 98% for patients with non-cirrhotic patients who were treated with an 8-week regimen of glecaprevir and pibrentasvir. Another regimen that's been utilized, although is more challenging to obtain in the United States, which combines elbasvir, the NS5A inhibitor, grazoprevir, the protease inhibitor, and the sofosbuvir, the nucleoside inhibitor, with or without ribavirin, also demonstrated remarkable results in patients with genotype 3 and cirrhosis. So these are three active DAA drugs, 3 different classes of drugs, with or without ribavirin. A relatively small study, but you'll see that 100% sustained virological response rate, whether they were treatment naive or treatment experienced. So whatever regimen we're looking at now, we're looking at over 95% cure rates. So you can't go wrong with any of these treatments that we're thinking about utilizing for patients with hepatitis C. Now, to synthesize all this information, we're fortunate that I'll point out there's a wonderful resource called hcvguidelines.org. Many of you, I'm sure, who are treating hepatitis C are very familiar, but it puts into context all this different data and makes recommendations for how you should select a particular regimen for your patient, with the preferred regimen as well as alternative regimens. And again, this is specific to the US. There are other guidelines out of Europe. Latin America will have their own challenges depending on which drugs are available in certain countries. But nevertheless, it puts it into great context where we are. So for example, genotype 3 patients without cirrhosis, they would recommend 8 weeks of glecaprevir or pibrentasvir, or 12 weeks of sofosbuvir, velpatasvir, again, to achieve those 95, 98, almost 100% cure rates. In patients with compensated cirrhosis, you'll see the only difference here is that they usually recommend the 12-week longer duration of treatment for the glecaprevir pibrentasvir regimen. Similarly, treatment-experienced patients who had been treated with PEG interferon and ribavirin without cirrhosis, the recommendations are sofosbuvir and velpatasvir for 12 weeks with a couple of alternative regimens that would work nicely in a lot of patients. And then if you have compensated cirrhosis, the potential for being treated with soft velpatasvir for 12 weeks, or I showed you that regimen, elbasvir, grazoprevir, plus sofosbuvir with or without ribavirin for 12 weeks as well, is a possibility. Now, as we treat more patients, even though very few actually fail therapy, we still have a few patients, and I'm talking about a handful of patients, who will fail treatment. And we're fortunate now that we actually have salvage regimens for these individuals, whether it's genotype 2, genotype 3, or genotype 1 either, as you'll see. So Polaris 1 was a study of a 3-drug regimen, 3 active DAAs of sofosbuvir, the nuke, velpatasvir, the NS5A inhibitor, and voxilaprevir, the protease inhibitor. This study enrolled patients who failed any NS5A containing regimen. They were treated with 12 weeks of this triple drug as a single tablet, or a placebo. And you'll see 96% of patients were cured of hepatitis C. And remember, this was a group that had already failed a prior DAA regimen. And when you looked at whether or not cirrhosis made an impact, it did not have a major impact. 99% cure rate in the non-cirrhotic population, 93% in the cirrhotic population. Similarly, Polaris-4 looked at 12 weeks of sofosbuvir, velpatasvir, voxilatravir, the triple drug regimen, or sofosbuvir, velpatasvir to see if there was an impact of the protease inhibitor. And what you see here is, yes, there was in this pre-treated population. 97% of patients who were treated with the triple regimen of SOF, Vel, Vox had a sustained response versus 90% of those treated with SOF, velpatasvir alone. And again, if you look at the difference between non-cirrhotics, the greatest difference was actually in the cirrhotic population, where 96% had a sustained virological response rate with SOF, Vel, Vox, compared to 86% in those who were treated with sofosbuvir or velpatasvir without the addition of that protease inhibitor. So again, boiling that down into potential treatment recommendations, if you have a patient with genotype 3 with or without cirrhosis who is experienced, who got treated with an NS5A inhibitor, the recommendations are 12 weeks of sofosbuvir, velpatasvir, voxilatravir. And if you're cirrhotic and you have evidence of a baseline variant or you're not sure, you can add ribavirin to further minimize that risk of relapse or breakthrough. I'll close with a few slides about genotype 2. Not as common around the world, but still has an impact, and we certainly see it over time. But two major studies, again, SOF, velpatasvir for genotype 2 in patients with or without cirrhosis. Similar idea, SOF, velpatasvir, 99% sustained virological response rate compared to the standard at the time, which was just sofosbuvir and ribavirin. Good response in genotype 2, 94%, but we're really leaving no SVR behind with SOF, velpatasvir. You'll see this study had 14% of patients were cirrhotic and 15% had prior interferon treatment. So 99% cure rate with sofosbuvir and velpatasvir. And the same with glecaprevir, pibrentasvir. Genotype 2 patients without cirrhosis. In this study treated for 12 weeks, you'll see 99% sustained virological response rate for genotype 2. And if you look at a study that looked at just 8 weeks of therapy, you'll see again 98 to 100% sustained virological response rate. And I'll just focus you on the blue bars for genotype 2 here. So again, AASLD, the HCVguidelines.org, recommending 8 weeks of glecaprevir, pibrentasvir for patients with genotype 2 non-cirrhotic, 12 weeks for sofosbuvir, velpatasvir, and in the patients who are cirrhotic, 12-week regimens across the board. And similarly, same kinds of recommendations for patients who have previously failed a DAA treatment. So in summary then, genotype 3 is a very common genotype throughout Latin America. And I didn't mention this, but it's actually becoming increasingly common in the United States. We're seeing a much higher rate of genotype 3 infection than we ever had in the past, and that's due to the opioid epidemic in the US. A lot of our younger patients are coming to us with genotype 3 infection, interestingly. The choice of regimens and the duration of treatment are affected by whether or not a patient is treatment naive or if they've had prior therapy. And if they've had prior therapy, was it just PEG interferon-based treatment, or did they also receive an NS5A inhibitor? The presence or absence of cirrhosis may impact the duration of therapy, and whether or not they're compensated or decompensated will also affect whether or not you can utilize a protease inhibitor-based regimen in that population. We see near universal effectiveness can be achieved for both genotype 2 and genotype 3 now with the current regimens, which are truly remarkable for all of us and our patients who have made this journey. And HCV Guidelines is a really great resource. So I urge you to take a look at that as well. So thank you very much for your attention.